So our next speaker will be Dr. Vahidy. He's a clinical epidemiologist and nationally renowned expert in stroke population health and outcomes research. He currently serves as the Associate Vice President of Research and Chief Scientific Officer at Tier Memorial Hermann and holds adjunct professor appointments at Houston Methodist Department of Neurosurgery and McGovern Medical School at UT Health Department of PM&R. He's authored over 120 peer-reviewed publications in leading neurology and cerebral vascular disease journals, and currently leads stroke, dementia, and delirium research funded by the NIH and PCORI. He serves as a faculty mentor on the NIH StrokeNet Training Core Committee and on NIH-funded T32 grants. His mentees have received several international awards in stroke and cerebral vascular disease research. He's a member of the editorial board of the Green Journal Neurology and is an associate director for Frontiers in Neurology and serves in grant review panels for the NIH and PCORI. Today, he'll be sharing his perspectives on how to contextualize patient-centeredness and outcomes for intracerebral hemorrhage.
Hello and good morning. Thank you, Dr. Zhang, for that introduction, Dr. Volpe for the invitation, Dr. Garg, I don't see her, Dr. Gadia. It's so nice to be back here. Seems like I never left. Without further ado, we'll dig into it. I'm very happy that in a stroke conference, in an early morning session, we are talking about intracerebral hemorrhage. And that is my passion, and hopefully I would be able to share some of that with the audience today. So these are my conflicts and disclosures funded through a few different mechanisms. My current employment, that Dr. Zhang said, is with Tier Memorial Hermann, but I have adjunct appointments and editorial board appointments. None of this conflicts with what I'm be talking about today. So let's jump into it. I will be trying to share my thoughts on 4 aspects. So what is the ICH disease burden right now? And I think the questions that we will be looking at is that what is the latest evidence nationwide and regional on ICH epidemiology and ICH burden, which outcomes have improved over time and which outcomes have worsened? And are the trends and the changes that we see in the outcomes similar across populations, and what are the consequences of these trends? Second, a great segue to Dr. Hodick's, from Dr. Hodick's presentation, we will talk a little bit about what we know today as far as ICH recovery is concerned. So what is the current and emerging evidence on ICH recovery trajectories? Do ICH patients plateau in functional outcome, or is there evidence of continued improvement in their outcomes over a period of time? And are the data generated that back this evidence representative and conclusive, and what models do we need to consider for enhancing our understanding of ICH recovery trajectories? Number 3, we will look at ICH outcomes. We will look at which ICH outcomes are currently tracked and reported, what is the understanding around outcomes beyond mortality and functional independence or functional outcomes, and what are the direct methods of quality of life assessment? Do these methods provide better patient-centeredness? And what is the implication of understanding all of this? And then finally, I would like to share some thoughts on the interpretability of the ICH evidence that is generated from clinical trials, and what are the limitations of interpreting and evaluating evidence utilizing the classical frequentist methods, and in which circumstances would additional interpretational approaches be helpful? How can we apply Bayesian methods to provide a little bit of a better and more enriched context that allows for patient-centeredness and caregiver empowerment and shared clinical decision models. So it's a lot. Just to be clear, we are talking about intracerebral hemorrhage. All the data that I would be sharing, which by the way actually comes from Houston Methodist and our work at Houston Methodist, and some of my team members and scientists who have led that are in the audience. All the data refers either to intraparenchymal lobar hemorrhage or intraventricular hemorrhage, and the intraparenchymal hemorrhage either deep or superficial. We are not talking about other forms of intracranial hemorrhages. This, as we all know, appears as a hyperdensity. It's pretty easy to pick up, comes in multiple shapes and forms, and has classically been very high mortality and morbidity associated with it. So let's just dig into the epidemiology and disease burden, the first aspect. I will be sharing 4 studies all done by our outcomes group over here at Houston Methodist. This is the first one that is in a stroke, led by Dr. Baku, who is in the audience. And what he did was that he looked at about 800,000 intracerebral hemorrhage hospitalizations across the country over a period of 15 years. And as a denominator, we took the US National Census data to really get to the incidence of intracerebral hemorrhage. And what he showed here, that the overall incidence is actually increasing for intracerebral hemorrhage over a period of time. It is very different depending on what race and ethnicity the patients belong to. The first top line is non-Hispanic black, and then this kind of brown line is non-Hispanic white, and this blue line is Asian Americans and Pacific Islanders, and this is the Hispanic patient population. So there are huge ethno-racial differences in incidence of ICH. Overall, it is increasing. What is also very interesting that if we look at the age breakdown, the highest gain is in patients between, or populations between 18 to 44 years of age. 38% increase in that population, followed by 33% among those between 45 and 64, and so on and so forth. And this increase is associated with a 16% increase in hypertension and a 130% increase in use of anticoagulants. So there might be some reasons why we are seeing this incidence. But the story from this study is that the incidence is increasing quite significantly, driven by ethno-racial differences in younger age groups. Next, again, Dr. Baku also looked at mortality or case fatality in ICH. This paper is published in Journal of American Heart Association, and what we found is that the overall mortality is declining. So what happens when incidence rises and mortality declines? Any ideas? The disease burden increases. We are going to have more ICH survivors because the incidence is increasing and mortality is declining. So that's the message, that what has happened in the last 10, 15 years and the trends that we are seeing, we are going to have more and more of ICH survivors that the healthcare systems and the communities would need to take care of. But there are disparities in the mortality situation as well. So what he was particularly interested in looking at urban versus rural disparities. And so the overall, these are about 900,000 ICH hospitalizations, again, the same 15-year time period. The overall mortality or case fatality is 25.3%. Let that settle in. 1 in 4 ICH patient who comes to the hospital is not going to survive their hospital stay. But the urban is around 24.9, and the rural hospitals is around 33%. So 1 in 3 ICH patients who is provided care in a designated rural area does not survive their hospital stay. So that's the disease that we are talking about. And the incidence of that disease is increasing. Just kind of want to belabor that a little bit. There is a faster rate of decline in urban versus rural hospitals, and the differences are primarily driven by patients who have minor or major loss of function versus extreme loss of function. So it's really like mid-severity, high severity, their mortality has declined. Patients who have very extreme loss of function, their mortality has been the same, which kind of makes clinical sense. Next, we looked at disparities. So Dr. Potter is in the audience. What he did, these are not national data, these are data actually from Houston Methodist. And he conducted this analysis where we know that social deprivation is a big indicator of outcomes, right? So, but what he was interested in doing was he was interested in looking at why does that happen? Why do populations and people who live in deprived neighborhoods have higher degrees of social deprivation, would have poor outcomes? And this was an exploratory analysis. He looked at a lot of factors, but what this paper showed was that high deprivation, which was measured by something that we call area deprivation index, it's a decile rank. So across the state of Texas, neighborhoods can be 1 to 10. 10 means that they are more highly deprived. 1 means that they are better off as far as socioeconomic indicators are concerned. So patients who came to us from very high deprivation, greater than 8, had this association with severe disability of death at 90 days, which is measured as the modified Rankin scale of 4 to 6. So it's greater than 4. And then, of course, we also noted that if they had a more severe stroke, that was also associated with poor outcome, which makes sense. But when we did the mediation analysis for this, it seemed that 90%, 94.1% of effect of area deprivation on severity is actually mediated through having a more severe stroke. And this probably, as every research project, raises more questions than answer questions. So why are people who live in more deprived neighborhoods having more severe strokes? And why the effect of poor outcome is mediated through that? Well, there could be several reasons. They could have higher burden of risk factors. It is also possible that they are coming to us late. So when we document their stroke scale in our electronic medical systems, it's possible we didn't have good arrival data, but we are kind of working on that. But it is possible that their stroke has progressed. It's more settled in. Just like with ischemic stroke, they just come in with a higher stroke scale, and there is not much to do for them. So, but the take-home point is that there are disparities in outcomes, and we really need to see and study why that happens. And I think the last one, yeah, there was a prediction that the slides are going to stick. 3 in a row have to happen. Okay, let's see. There you go. Again, this study was led by Dr. Baku. This was published in JAMA Network Open, and he was specifically interested in looking at Asian American and Pacific Islanders. We know when we look at global data that ICH incidence is much higher in Asian countries as compared to European countries, and Asian populations as compared to European populations. However, there is relatively lack of data on Asian Americans and Pacific Islanders who live in the United States, right? So how do these epigenetic factors sort of interact and decide the disease burden or influence the disease burden? So he compared that, and that is published. And what he demonstrated here is that this line is for Asian American and Pacific Islander individuals. So this is not looking at the incidence. This is looking at, of all the strokes that happen in the United States, population aggregated, the proportion of ICH of those strokes. So if you think about that 100 strokes happen, what percent of them are brain hemorrhages or ICH, and what percent are other strokes, including ischemic stroke? The highest proportion of ICH happens in Asian American patient population. So kind of replicating what we see in global data, that is also happening in the United States. And it might not be a surprise to many, but Asian American Pacific Islander population in the United States in the last 10 years has been the fastest growing patient population, faster than Hispanics, faster than any other patient population. So that is the future of our US population, and we really need to be paying attention to that. So with that, I move on to the next thing that I want to talk about is ICH recovery trajectories. And there's a lot to present over here, but I chose one publication that comes from an analysis of 2 of the larger trials that had happened in the ICH field, which is the CLEAR-3 trial and the MISTY-3 trial. And I'll be talking about the MISTY-3 trial a little bit later as well, but essentially these were intervention trials and these were surgical trials, right? And I think this is a very neat analysis, and what the investigators did over here is that they said, okay, we have a group of individuals who in the classical definition of recovery have plateaued by day 30. So by day 30, these ICH survivors are either in an MRS score of 4 or MRS score of 5. So 100% of these patients at day 30. And let's see what happens with these patients over a course of time from day 30 to day 180 to day 365. And what we see here is that in a classical sense, we would think that these patients have plateaued, but without any intervention, these patients are improving in their functional recovery. As a matter of fact, I think I had the percentages here. No, I don't. if we calculate this, it was about 30% patients went from 4 or 5 into 0, 2, or 3, and about 40% patients went into 4 and 5. So, and there's a very detailed analysis in this paper, and it's a really good paper. But I think the take-home message is really that ICH patients do recover over a period of time, and there is a continued spontaneous recovery all the way, at least per this evidence, till day 365. So should we just take this and say, well, the evidence is conclusive? Are there any guesses to what's wrong with these data, or what's the limitation? Well, here's the limitation, right? These data come from clinical trials, right? Selection of patients into clinical trials is very, very, very selective. So when we think that ICH patients recover till 365 days, that cannot be a universal statement, because these are the two concert diagrams from these two clinical trials that I talked about. And if you see that the number of patients that were assessed for eligibility versus the number of patients that were enrolled, this is 2.5% and this is 4.7%. Right? And if the counter argument to that would be that, oh, these are surgical trials, and of course in surgical trials you have a lot of inclusion-exclusion criteria, so you should really not look at disproportions. Well, the picture is not any more better in non-surgical trials as well, right? So these are the two big trials for hypertension, for blood pressure control in ICH, and these are big trials for ICH, 1,000 patients and almost 3,000 patients. But look at the differences in people who were assessed, patients who were assessed for eligibility versus patients. So any recovery data or any trajectory data that we are analyzing or doing a sub-analysis of clinical trials, we always have to look at through the lens of bias of which patients were actually selected in these clinical trials. And unfortunately, the best data on outcomes or long-term outcomes comes to us from clinical trials, right? Because we don't have what we think should be the solution, which are learning healthcare systems, right? As a part of learning healthcare systems, we should be looking at all of our patients, regardless of whether they got into a clinical trial or not, and collecting their comprehensive data, understanding that data, and tracking their outcomes. And what we have done at Houston Methodist is that we have created a pipeline to do that. So our neuroinformatics pipeline, again, this is published, and this was led by Dr. Potter, where we look at all ICH patients, as a matter of fact, all stroke patients, and it has been combined with some other registries that we have at Houston Methodist, including the HOPES registry, where the approach is really to look at the comprehensive picture of data that come to us through EMR and follow up these patients, so then we can have a better understanding of what the true trajectories of recovery are. I'm not going to talk a lot about this, but this is the solution to countering the bias that we have in the data. We have other publications from the same registry. We did the same for COVID while we were here, and then there's other publications that we have done to talk about the concept of learning healthcare systems. But I would move on to sort of like two other things that I want to talk about, which is the outcomes, especially the outcomes in terms of direct assessment of quality of life, and then the last piece on clinical trial evidence. So beyond mortality and functional recovery, that's kind of like what I've been talking about a little bit more. What do we know about recovery and outcomes for brain hemorrhage patients? Actually, a not whole lot, right? So a very important area to consider is cognitive outcomes, right? So in cognitive outcomes, Dr. Potter did this review a few years ago, and without going into too much detail, what is evident is the variability, right? So these are small studies. They usually are not standardized in how they measure the cognitive performance. There is a lot of heterogeneity of ICH patients, and what we get at the end is fairly inconclusive findings of what cognitive trajectories are. Now, there are some big clinical trials right now that are enrolling, that are addressing and trying to study this better, but the current evidence really requires for those clinical trials and those prospective studies to happen. What these data showed is that there is an initial sort of like the proportion of patients with impairment they kind of decrease and then they increase over a period of time. But essentially, the message from this paper was really that there is a lot of heterogeneity and there's a lot of requirement for systematically collecting cognitive outcomes. Now, the other outcome that I want to talk about is our quality of life outcomes. So if we think about a quality of life outcome and we think about patient-centeredness, I think where the modified Rankin scale is restricted is it is a purely functional scale. And actually, it was not developed for stroke patients. It was developed for orthopedic patients. But the field adopted it, and we use it religiously, and there are different versions of it, how we use it. But if we think about it, what we say as clinicians or as researchers, that if a patient is able to walk, or if a patient is able to get out of their bed, their outcome is better. The question is, does the patient think that their outcome is better? And the obvious question is that is an MRS scale of 3, which in ICH patients we consider to be a good outcome, has similar valuation for every patient. What about an individual who was the sole bread earner for their family and was a truck driver, and they end up with an MRS of 3? Versus what about a patient who was retired and were already in some kind of an assisted living condition, and they end up with an MRS of 3? I think these are two very different patients who would have a very different valuation of what that health state means to them, health state being an MRS of 3, right? So we did some work on this, and we employed what are called direct measures of quality of life. And this is a little hard, especially for our patients to understand, but we wanted to see what is the feasibility of applying this in ICH patient population and what results do we get. So this was a project that when I was at UT Health, we got funded for an ICH grant, and we did it over there. But essentially, what I'm trying to project over here is that we started from approximately 600 patients, and we were actually able, and the measure is called standard gamble, and I will talk just very briefly what standard gamble is. But we were able to do assess patients with this standard gamble in about 97%. Of those who were eligible, 97% of patients we were able to obtain this assessment. And what we demonstrate then that we were able to repeat this assessment at 90 days. And we had fairly high percent of completion, 76% even at 90 days for the standard gamble. So what is the standard gamble? The standard gamble is exactly what it sounds like. It is a gamble. So we question the patient or their caregiver for a hypothetical state. It's a hypothetical question. And the hypothetical question goes something like this. That let's say that you have some percent chance of attaining perfect health state with a magic pill, right, with a treatment. Would you take that treatment? So the way it goes is that we talk to the patient and give them this question and say, let's say there is a magic pill, and you take this pill before going to bed. And then you wake up next morning, and you are going to be in a perfect state of health. All your ailments are going to be gone. You're going to be free of everything. The other gamble is that the other outcome could be that you can peacefully die in your sleep. What percent of that perfect state of health should I tell you that you would be able to take that chance? You would be able to take that risk. This is a very direct measure of quality of life. It doesn't depend whether the MRS is 3 or MRS is 4 or MRS is 5 or even MRS is 0 for someone like me, right? So I can ask that question myself. I have chronic backache. It's like, right? So that is the question. And then essentially, the percent that we give them, we say, well, would you take the pill if there is a 100% chance of recovery, if 100% chance of perfect state of health? Most logical folks would say, yeah, sure. I mean, we get all kinds of answers. There are ethical reasons, there are religious reasons. Some people say, I don't believe in a magic pill or what have you. But besides that, and then we titrate that risk. Okay, if you will take it at 100, would you take it at 90? Would you take it at 80%? And what is the flip side of that 80 or 90? The flip side of that 80 or 90 is passing away. So if 90% chance is for perfect recovery, then 10% chance is for passing away in sleep. And look at the data that we got. So in this graph, the modified Rankin scale is at the bottom, and the utility index is over here. So we did two comparisons. We had a direct utility index, which is the standard gamble, and we had the indirect one, which is the EQ5D, which most people know. EQ5D has 5 domains. There's different versions of it, but those 5 domains tend to follow the modified ranking functionality very, very closely. It again assumes that if you can button your shirt, if you can comb your hair, if you can walk a certain distance, then your quality of life is going to be better. So, and then the 0 to 1 you get by, if a patient said that I will take a 90%, I'm okay with taking a 90% risk for perfect state of health, then their utility is 0.9. And if they say I'm willing to take 50%, it's 0.5 and so on and so forth, right? So what we demonstrate over here is that as the modified Rankin scale is increasing, the utilities are generally declining, which is expected. But the true finding is the difference between these bars, which should come up, but it's not. But anyway, what we see here is that at lower levels of, or at higher levels of functionality, low modified Rankin, our utility index for the standard gamble, which is the blue bar, and the EQ5D are pretty much the same. But see what starts happening when you have higher levels of disability. When you have higher levels of disability and you ask this direct question from the patients, patients value their life, right? So individuals who are in MRS of 4, their average standard gamble is 0.96. They are only willing to take approximately 5% chance. They value their current state of health in an MRS of 4, which we generally think it's like MRS of 4 is really bad, right? And MRS of 5, absolutely bedridden patient, valuation of 0.6, only willing to take 40% chance of peacefully dying in sleep, would take the pill for a perfect state of health. I think this is really important, and this is not just our study. There are other studies, actually in ischemic stroke patients, that also demonstrate that. And we have a publication in review in JAMA where we have taken the data from, again, from clinical trials, and we are demonstrating the same thing as far as direct assessments are concerned. Here are the bars. So when we look at the lower MRSs, the differences are between 14 to 15%, 26%, and then when we go to 4 and 5, there's 57% and 70% higher valuation when you ask the patients these direct questions. So there's something to think about. We'll come back to it in conclusion. Finally, I want to talk about how we look at evidence from clinical trials and what kind of big decisions we end up making on the frequentist p-value, and what is some other ways of thinking about that. So as you all know, that frequentist p-values, they provide a binary decision point of potential effectiveness of interventions. We as scientists live our careers around the p-value of 0.05. We get 0.049. We open the bottles, we celebrate. We get 0.051. We go back to our statistician and go like, you know, I mean, what's happening over here is 0.051. How can we, papers get published with 0.05. And this is a completely arbitrary binary cutoff. And that really doesn't mean anything. I'm not belittling the whole frequentist approach over here, but I'm saying when we make huge clinical decisions, life-saving potentially decisions, we should think about what is the basis for that decision. So what we think is that in certain conditions especially, there is a nuanced interpretation of interventions may be warranted, particularly if the intervention does not show harm and the condition has high morbidity and mortality under the current standard of care. And I will apply this to ICH, of course. What Bayesian methods do is that they provide a probability of treatment effect versus making binary interpretation of clinical interventions. And without going into a lot of math, the Bayesian outcome will tell us that what is the probability or chance, easy word for probability, what is the chance of attaining a certain threshold of clinical effectiveness, rather than saying that you collected all these data and your p-value is 0.055, so the intervention doesn't work. Because that's the interpretation you get when you think about things in a binary context. So the underbelly, of course, of Bayesian analyses is that they rely on prior data or information, and the biggest critique is that you can set that prior expectations in a positive side, and you're going to get a positive result, right? So I'll show you how that is handled. And given the probability of treatment benefit, patient and caregivers can be engaged in a more meaningful decision making. So, well, let's move on, and then I will share my final thoughts on this. So MISTY-3, I told you I'll talk about MISTY-3 a little bit. MISTY-3 was a randomized controlled trial. It evaluated the effectiveness of minimally invasive surgery to evacuate hematoma among ICH patients. About 500 patients were randomized to either receive the MISTY intervention, which was minimally invasive, or standard medical care. It was blinded endpoint assessment. It did not show efficacy in the classical sense of a frequentist trial. The primary outcome was getting to the MRS of 0 to 3 at 365 days, which was observed in 45% of MISTY patients and 41% of patients who received the standard medical care. This p-value was 0.33. But when we look at death, for example, 7-day death, 1% for MISTY, 4% for standard medical care, p-value of 0.02. 30-day death, 9% for MISTY and 15% for standard medical care, p-value of 0.07. If we look at the safety profile of the MISTY intervention, symptomatic bleeding, 2% MISTY patients, 1% standard medical care, 0.33 p-value, brain bacterial infections, 1% versus 0%, and 30-day one or more SAE actually lower in the MISTY group, 30% MISTY versus 33% standard medical group, p-value 0.01. For those who take care of ICH patients, this is not the latest evidence in minimally invasive surgery. There's another trial that has been presented at the ESOC this year. But if you're armed with this information, what conversation can we have with the patient or their caregiver? Well, it can go in different ways, right? We can say, well, we had this big trial, it was funded and several sites, and we spent years and years of federal money. But 45% MISTY, 41%, so we don't know whether it works. The p-value was 0.33, so it doesn't really work. So please decide if you want this intervention for your loved one or not. That could be one conversation. The other conversation could be, well, it showed some benefit on mortality. It was not powered. Mortality was not the primary outcome. So even though the p-value we got is 0.02, but we really can't say that it worked for mortality, but we don't know, right? Was it safe? Yeah, we think it was safe, right? There was no serious adverse events. Actually, the adverse events were higher. So we can kind of think that it is safe, but we really don't know whether it was effective. Please decide on your own. Here we are. What we can do is to look at the same data. This is not altering the data, but we can look at the same data and derive certain different interpretations. And we did that. So we took MISTY data, and we did Bayesian analysis of those data. And again, this work has been led by Dr. Baku, who is sitting right at the back of the hall. And this was published in Neurology. And I'll just take a minute to explain this, what's happening over here. So these relative risks are essentially chance of seeing any improvement. If a relative risk is greater than 1, we are not saying it's a 10% chance, it's a 15%, which is any improvement, as compared to if you don't get the treatment. This is a 2% chance of improvement of 2% better if you get the treatment. This is a chance of improving by 10%, and this is a chance of improving by 52%, which MISTY really wanted to show, because their power and sample size calculations was based on that. And what Dr. Babku did was like, okay, this is the 365-day outcome. He said, I'm going to look at multiple different priors. You remember I said that the problem is where you set your prior expectation. So if you set a very positive expectation, you're going to get a positive result. He said, well, I can set multiple expectations. I can set a neutral expectation, a positive expectation, a negative expectation, which is called a skeptical prior, or I can look at MISTY-2 data and MISTY-1 data because there have been previous trials, and I can use the values from there and set my expectations, which is the scientific way of doing it. and then I will give you the probability or chance of achieving all of that, right? So this is a minimally informative prior, which means we don't know how this is going to go. This is an enthusiastic prior where we feel this is going to be really helpful. This is a skeptical prior. And you remember when I was talking to you how you're going to talk to the patient. This is how we approach the patient. Depending on the physician, depending on the provider, we have our beliefs, right? There might be a surgeon who does minimally invasive surgery and who really believes in it. So they are going to have an enthusiastic prior, right? There might be another physician who would be like, I don't really know, and there might be someone who's like, no, this doesn't work, right? So when we set these priors, we can get to the probability of treatment benefit. We can say to the patient, we don't think there is any chance that you have 52% chance of doing better, but we do think that we have between a 70 to 80% chance that you're going to see some benefit, right? Remember, the safety is okay, right? So we are not harming the patient. Now we are arming ourselves with a better conversation rather than saying p-value of 0.033, right? And then he looked at the data-derived prior, and the strength of all of this is that the probabilities are pretty much in similar range. So any benefit between 70 and 80%, 2% benefit, somewhere between 64, 65% range, 10% benefit, 30%. There's one condition with enthusiastic that it reaches 55%. 52% benefit, no chance. It's just a more enriched way of empowering patients for a shared clinical decision-making model. Similarly, what he also did, that was MRS of 365. This is mortality, same concept, relative risks. Less than 1% means less mortality, some benefit, 10% less mortality, 20% less mortality, 30% less mortality, different priors, different results. Now we are saying that if your loved one gets this treatment, there is pretty much a 90 to 99% chance that they are going to be better off in survival. And remember, survival is important for ICH patients, right? We saw that when we did the direct standard gamble, that patients in their MRS states of 4 and 5 value their life, right? So if we think that survival is important and 10% chance of survival, which most of us think is clinically significant, if there is a 95 to 80% chance of 10% better survival, this is a more enhanced way of approaching our patients and empowering them in this shared clinical decision-making model. So the ICH burden, the incidence is increasing, which is primarily driven by younger populations, and hence will result in greater loss of productivity. There is decreased overall mortality, but that is probably driven by specialized neurological and critical care, and there are disparities in incidence and treatment outcomes. We saw that there is growing evidence of long-term spontaneous recovery as opposed to plateaus in recovery. Data are limited and biased towards patients enrolled in clinical trials, and we need to develop learning healthcare systems. Most outcome assessments are limited to mortality and functional dependence. There is lack of data on cognitive and quality of life assessments, and when we do direct quality of life assessments, we see that patients with higher level of functional disability actually value their life more than what we expect. And then finally, the current modalities for evaluating effectiveness and efficacy of evidence from clinical trials is limited, particularly given ICH burden and lack of treatment modalities, and Bayesian methods may provide meaningful context to empower patients in clinical decision-making. With this, I come to the end of my presentation. Shameless plug here for Tier Memorial Hermann. We receive patients from all over. Send us your patients. This is the team that we had developed and built at Houston Methodist. Many of them are still here. I have an adjunct appointment. We still work together, and all of this work is not my work, it's their work. I just get the pleasure of standing here and presenting it. Thank you so much.